Welcome to the Heart Factory. Now, because of the involvement of the sinuses, so they have a tendency to spread, is it?
Yes, sir. The spread first, as we discussed, it is starting only in the sinus.
Okay.
After that, the mode of spread is around 3 to 4 waves.
Okay.
First thing is direct invasion.
Okay.
It will invade the sinus bone. It will start eating the bone. Fungal osteomyelitis developed, and this bone will be dissolved. It will be crushed and it will be swollen by the fungus completely.
Okay.
So since the nearby structure from the ethmoid and maxillary is orbital area, this orbit bone will get eroded and it will enter the orbit.
Okay.
So first point is direct invasion. Second is angio invasion. This you can confirm through histopathology. It will start invading the blood vessels and it will travel through the blood vessels, particularly at the night, where you will have steroids and glucose to be glucose high.
Okay.
So it will nicely travel in the night time. So second thing is angio invasion. Third thing is neural invasion.
Okay.
It will even invade the nerve. It will invade the perineural fibers and it will invade the nerve and it will compromise, it will sever the nerve completely.
Oh.
So all these cranial nerves, 12 cranial nerves are existing from the skull base, which will have the entry point all in this paranasal sinus, V1, V2, V3, trigeminal nerve, facial nerve including. So all these can be eroded. So all patient can have from cranial nerve 1 to 12 symptoms. All 12 cranial nerves can be affected. We have seen patients with dysphagia due to 8, 9, 10 facial nerve palsy. Eventually, patient may have facial nerve palsy, loss of sensation over all this region. Any nerve from 1 to 12, all nerve can be affected. This is third mode. Fourth mode is basically, this is now very common in this pre-COVID area. All this COVID is causing a prothrombotic state for our patients in all our human body. That is why we are giving Clexanes. Even in lung, the main pathology is prothrombotic state.
Correct.
So all these prothrombotic patients having fungus is prone for fungal embolism.
Okay.
So even the fungal without growing much, if it is in a maxillary sinus also, it may be isolated only in the maxillary sinus, but still patient may lose the vision via fungal emboli entering into the central retinal artery.
Okay.
And causing occlusion, and vision has gone. So even a small amount of fungus causing a big problem. So that is why many patients may presenting with straightly loss of vision or eye symptoms. So this even the local brain, the bone, everything will be intact, but they will have lost
vision. Have been lost.
So this is a so pathetic state because patient is getting worse symptoms very early. Even when they present to us, they are presenting with loss of vision.
Since it has made a comeback, sir, and as you said, roughly around 12,000 cases reported in a period of 1 month in India alone. So how do you investigate and on what basis you start your treatment? What is the extent of treatment?
Yes, sir. Previously, as I said, diagnostic and nasal endoscopy will give my suspicion. Followed by, I'll take an MRI to confirm, and the most important point in MRI is to find out the extent of the disease.
Okay.
Whether it is invading the perisinus region, I will assess the palate, I'll assess the turbinate, spinopalatine foramen, infratemporal fossa, periorbital region, orbital apex, including cavernous sinus, skull base, and brain. Because the last sign of the advanced stage will be multiple infarcts. Patient will be thrown up for infarcts.
Okay.
If cavernous sinus is involved, the mortality is so high, it is around 70 to 80% mortality. If a cavernous sinus involved, they will lose both the eyes.
Okay.
So cavernous sinus is the pre-stage. The last stage will be infarct. Patient will end up with hemiplegia and carotid artery involvement, and finally we may lose the patient.
So you can see all this through MRI.
So MRI will make me to stage the disease, to assess the extent of the disease, so that I'll explain the patient how far it is involved. So if it is very minimal, first stage it is exclusively to the sinus.
Okay.
Second stage, I'm just roughly staging it. Second stage will be involvement of orbit. Third stage will be cavernous sinus.
Okay.
So in the first stage, if it is exclusively into the sinus, I can do an endoscopic debridement.
Okay.
I'll do endoscopically without any scars. I will just enter through the nose with like normal sinus surgery. I will enter the nose and I will debride the dead tissues. Turbinate, sinus bones, everything whichever is necrotic to me, I'll debride it. The aim of debridement is three purposes. One is to reduce the fungal load. Second is to confirm the histopathology and culture. Third is, this is the most important thing we are doing a surgery. The surgery has a big role because of this point. This the prime treatment of mucormycosis is injection amphotericin, which is an antifungal drug. The antifungal drug of choice for amphotericin. For mucormycosis. Mucormycosis is basically a medical disease. This amphotericin has to go through intravenously and it has to reach the target area. If your target area is necrotic, this drug is not going to reach, sir. Definitely it's not going to reach. The idea of doing debridement is we are debriding out all the necrotic area so that the target area will have the amphotericin through the healthy blood vessels. So that is the basic principle of the surgery, aim of the surgery. So which we are seeing necrotic, we will remove it. We will do endoscopically to the max so that they will get less morbidity. Some people are doing open. They will do straightly total maxillectomy and orbital excenteration completely. They will leave it open. Even the skin they are removing if there is a skin sign. But if there is a skin, you have to remove. But if you do an aggressive surgery, that is total maxillectomy, including palate, orbital excenteration completely. So then after it gets healed, then they will think about reconstruction or obturator. But endoscopically, what you can do, you can assess the disease properly and you can remove the necrotic region. You can do orbital clearance rather than excenteration.
Okay.
The difference between excenteration and clearance in simple terms means you won't lose the eyeball.
Okay.
If you do an excenteration, that is completely you will lose the eye socket itself. When you do an orbital clearance endoscopically, will make the eyeball intact because eyeball will not be most of the time affected by fungus.
Yes.
Periorbital will go through the nose and will enter the periorbital region. Will give complete clearance. We can give clearance to sphenopalatine foramen. We can give clearance to infratemporal fossa. You can drill out the palate, so the patient can have less morbidity in endoscopy. If the cavernous sinus, the third stage, as I said, if it is an orbital only involvement, I can even approach the orbit endoscopy. If a cavernous sinus is involved, then you have to think of, and the patient presenting with the loss of vision, then you have to think of removing the eyeball also.
Okay.
Because there is no point in preserving and you can remove it.
That's more extensive.
So that is extensive. And if there is a skin involvement, then you have to lose this cheek skin also. And it will be left open for some months. So once it get granulated, once it get healed, then we can think about flap or a graft. So this is how the treatment progresses.
This is surgical. Apart from this, sir?
After surgery, or if the patient comes itself, we can start the drug. After surgery, as I said, mucormycosis is not a surgical disease, it's a medical disease. And the injection antifungal drug which is available is injection amphotericin B, which has to be in a liposomal form. There are 5 forms of amphotericin.
Okay.
Among that 5, there is normal form, that is only lyophilized form, then emulsion form, liposomal form, then liposomal solvent form, then solidification form. This solidification is under research. These 4 are available now. Among the 4, this liposomal amphotericin is commonly used and it is renal safe. Even though it impairs the renal function, to some it won't cost much. So this treatment after post surgery, it has to be followed by injection amphotericin. Depend on the disease, depend on the institute protocol, it has to be given 5 mg per day to 10 mg per day per kg. So average 5
per kg.
Yeah, averagely we will give 3 vials to 6 vials per day.
Okay.
For 2 to 3 weeks we will give.
Okay.
And every alternate days it has to be assessed through the endoscopically, reassess whether again any necrotic tissue started developing. Most of the time this palate start getting necrose.
Okay.
So second time patient may go for a revision debridement with palatal debridement or palatal complete removal. That will be done subsequently if it develops. So subsequent everyday endoscopic surveillance will be done, and if needed debridement will be done on a SOS basis. Then this injection amphotericin will go. After 14 days, you can monitor via some, there is no particular blood test to assess this. CRP can be done. CRP will assess your disease intensity status. After 2 to 3 weeks of injection amphotericin, patient will be converted into second line drug. which is tablet posaconazole or syrup posaconazole.
Posaconazole. Okay.
That has to be taken 800 mg per day. That is 8 tablets, 4 tablets in the morning and 4 tablets in the night for 2 weeks.
Okay.
And patient will be discharged and patient will be assessed on OPD basis, which will be converted into syrup posaconazole. We have to assess at least 2 months, and patient has to be fungal free. And in that, alternatively, his sugar status has to be assessed, and all other morbidities has to be addressed properly, particularly renal function has to be assessed. If it is posaconazole, liver function has to be assessed. And after 2 months, if he is disease free, then the rest of reconstruction. If it is done endoscopically, zero reconstruction.
Okay.
If it is done open, then it has to be followed by reconstruction. So patient, this morbidity will be addressed later.
So basically, what Dr. Isaac has to say is, if you have an advanced form of mucor disease involving the sinuses, the orbit or the cerebrum, you are more likely to undergo extensive surgery.
Yes, sir.
And the pain of the patient is likely to be prolonged. Now, what is the outcome of your treatment, sir? Say a patient is coming in an early form of just a crust is there, small amount of the fungus is there, you have debrided endoscopically. How he'll recover well?
If the patient,
there is no dead tissue.
If the patient's disease is only confined to the turbinate, not even sinus, since it starts in the nose has 3 turbinates. It's a comma-shaped structure, and if it is only isolated to the turbinate and it is not in any other region, patient will have 100% cure about the disease, because we will debride out nicely. We'll give an amphotericin so that it won't recur, or it won't again, the fungal load will never happen because of amphotericin. Side by side, if we monitor the glucose or whatever predisposing factor for the fungal, if it is avoided, definitely it will give 100% cure. If it is isolated to the sinus also, this applies. Even if it is isolated to sinus, I have seen patients, if isolated in the initial, for the past 3-4 days, if it is isolated to sinus, if I am debriding out and supported by the injection, they are giving good results. But if it involves the orbit, or if it involves this cavernous sinus, the prognosis is completely different. But still, I want to make sure everyone makes this point, because even if it is isolated sinus, as I said, this fungal embolia is common in post-COVID, post-treatment or post-amputation, even post-injection. Proper surveillance is must. Patient has to visit the OPD at least a weekly once for at least 1 month to 2 months. They have to watch for a fungal embolia. If a fungal embolia is starting, that means there is some amount of fungal is being residual. So he has to be put on another booster dose of amphotericin.
Is it readily available, sir, amphotericin, liposomal?
Sir, initially, since it is a rare disease, as I said, just remember, sir, how much they would have had this injection amphotericin be in the pharmacy or in the marketing, in the manufacturing field. So initially, when this disease was out in the north itself, this amphotericin got shortage. So whatever we are having, the manufacturers or the pharmacy people or dealers which we are having only was supplied. There was no new amphotericin which was able to produce, because most of the ingredients are German patent or UK patent things, and they are very busy in making vaccines. So it is not that easy to make this liposomal amphotericin. It's not easy to make, sir.
So there is a shortage of medicine.
Yeah, sir. Initially in India, the whole India, only 7 companies were making, sir. For the past 2 weeks, government has given another 5 companies approval for it. But still, they have to depend on overseas companies for patency and ingredients.
Correct.
So it will take some time to get, sir. But still, government is putting so much effort to get the vials properly, so that it has to be given properly at the earliest.
Now, what is Candida doing? Candida is the commonest of the fungal infections for all the audience. How are you seeing Candida, sir? Is it parallelly on a rise?
Sir, Candida is, so basically, sir, fungus, there are a lot of fungus, sir. Candida we have, all dermatitis fungus we have, aspergillus we have, rhizobus we have. Basically, fungus, we can, in layman term, it is safe fungus, danger fungus. I used to say in my patient.
Okay.
It is safe fungus, danger fungus. In a technical term, we can say invasive fungus, non-invasive.
Yes.
Most of the candidiasis, almost 99% is non-invasive, sir.
Okay.
It will mostly be a cutaneous or a oral or oropharyngeal candidiasis. We are getting, sir, post-COVID patients, so many patients comes to my OPD having oral ulcer, tongue ulcers, even in oropharyngeal, they are having oral because of excessive use of antibiotics and immunosuppressants, they are getting. But it will be treated accordingly. So tablet, it will be started with a local treatment. A normal hexidine gargle wash, candid mouth paints are available. Clotrimazole paint, followed by, if not tablet fluconazole, adequate nutrients, oral hygiene will make that fungus to settle, sir. That is not, candidiasis is not a big deal, sir.
But that is also always.
Yeah, that also there, sir. This fungus will come if a patient is immunocompromised.
What has the general population to keep in mind now in this COVID era, whether he is exposed to COVID or not, with regards to hygiene of the ear, nose, and throat? What is your advice to the people so that he or she doesn't get into this problem of fungal infection?
First thing, wear proper, clean, hygienic masks. If it is now in the second wave, double mask is so prevalent now. If they are doing double mask also, they should be very careful. As I said, more than 8 hours, your cloth mask or whatever mask has to be removed.
Okay.
No excessive usage time for mask.
Okay.
First thing, sir. Second thing, they should avoid maximum steam inhalation, native inhalation. Normal steam is different, sir. All this native usage of this turmeric powder and whatever they are using. So people should stop all these natives, particularly steam inhalation. Second thing. Third thing, third thing, it should be very hygienic. Always, as for a COVID, this fungal can be avoided by having a fungal environment in your house, proper sewage treatment in your house, proper floor cleaning. Don't make, particularly fruits and vegetables, if it is not consumed in 1 or 2 days, it has to be checked out. Don't keep in the fridge for a long time. Defrost your fridge properly. All these food items which will have fungal commensals. Clean your utensils accordingly. Dry it out. Don't make wet clothes. Don't dry your clothes inside your house, outside the house. So these are all small things which we used to tell for all the time. So that applies here also. Second thing for the public is post-COVID, they have to do 3 important things. First thing, if they are diabetic, they have to monitor 3 times blood glucose properly, and they should consult a diabetologist for their sugar levels. If it is going above 300, 200 above, okay, sir. But 300, if it is going above 300, it definitely has to be monitored with either insulin or a hypoglycemic drugs. Otherwise, you will lose your immunity. First thing. Second thing, since your immunity power is less for another 3 months in post-COVID, make sure you are not exposed to any other things. Even in particularly first 15 days. I have seen a case mucor starting from 2nd day to 7th day. So I can say it is 1 month at least you should be very careful. As I said, this fungal force, all these hygienic things, and you should not be exposed to, or you should not expose yourself to immunosuppression. This is post-COVID. This is second important thing. And the third important thing, warning signs. Whichever warning signs you have, like unilateral headache, which is not coming down by taking your painkillers at home, particularly at night, please come. If it is more than, if you are putting for 1 tablet or a 2nd tablet, when you are going to put a 3rd tablet itself, please come if you are a post-COVID and if you are a diabetic. First warning sign is that, sir. Second important finding sign is numbness. Make sure there is decreased sensation over the one side of your face or your palate. Second important warning sign. Third, your nasal discharge, which if it is greenish or a yellowish or a blood stain or a blackish, you have to. Eye signs like minimal eye swelling, diplopia, then loss of vision, of course, then complete eye drooping of eyelid, that is ptosis. You have to come immediately. So these are your warning signs. If it is eye sign, definitely patient will come. But before the eye sign starts, if we catch up in this sinus phase, it will be very useful for patient. So that is very particular, like unilateral headache and this nasal discharge, loose tooth, and any ulcer over the palatal region. Please come and visit once. Have your endoscope done. Not a local doctor, better an otorhinologist, ENT doctor, so that he will put a nasal endoscope and see. He will assess the status of the mucosa, then he will proceed. So this is the important thing for a post-COVID patient.
If you have any other questions with regards to the involvement of the ear, nose and throat, or how Anything else you want to know about Mucor or Candida, you can drop your questions in the comment section. I'll get back to Dr. Isaac and get an answer for you. And as usual, if you are liking this video, please click the like button and subscribe to my channel. Please don't forget to ring the bell as well to be notified of my next video well in time. I appreciate your time watching this video. Thanks for watching. Thank you.